Thank you everyone for joining today. This is the third and final session of the North Dakota Brain Injury Learn at Lunch session. And today's topic is after your client screens, if they screen positive, now what? So Carly Endries is going to be presenting today, and I'm sure Rebecca Quinn may pop in as needed. I'm Kelly Larson, and I work for the Behavioral Health Division. So I'm hosting today, so I'll kind of keep track of the chat and try to answer questions as needed. I did put a note in there just so that all of you are aware. At the end of the chat, I'm going to be putting up a survey link, and that would be able for you guys to answer questions on a survey. And then at the end of that survey, you'll be able to click on it, or click on it to answer questions or to get your CEU or attendance. So that's what you'll be able to do. If you were not able to get last week's or the weeks prior, that information will be in that same one as well. If you do want a copy of the PowerPoint from this week, you will need to put your name and email address in the chat, because I don't have a copy of that since this is not a required registration event. So just put your name and your email address in the chat. So welcome, and without further ado, I will let Carly take it away. Thank you.
Thank you, Kelly. Appreciate you
Yes,
guys having
thanks.
us.
Of course.
Yes, like Kelly said, this is our third and final, but hopefully we'll be back for some other topics too at some point. This is our ndbin.org is our website. Lots of great info on there. We have that 855 number that Nikki Livdahl answers. I did throw all of our contact info in the chat as well for you, but I am Carly and I'm Senior Project Coordinator at the Brain Injury Network. There's my email and my phone number. But I did, like I said, through the contact us page in, because we are up to 4 staff members now. We have Rebecca Quinn as our director, and then myself, and then we have Nikki Livdahl in Towner and Shannon Stanky in Fargo. So feel free to check out our individual contact info there. But let's dive in. So this is what our screener looks like. So hopefully you're choosing to screen clients that you see on a regular basis. Hopefully universally screening everyone that comes through your door. That would be best practice. But even if not, if you're just listening for certain things, these would be things to keep in mind that you're listening for. You're listening for things like loss of consciousness. From lots of different reasons we can get have a loss of consciousness, but you can see the prompt there under number 1 has a big list of all the reasons how someone can lose consciousness. Number 2 is looking at multiple mild injuries, so maybe lots of concussions or lots of like dazed and seeing stars. Drug overdoses and chokes and strangulations you should be listening for, as well as anything kind of more like on the doctor side of things, so epilepsy, strokes, tumors, brain bleeds, hemorrhages, anything like that. So, I apologize. So yeah, if you can administer this to all your clients, that would be ideal. And so then this is not a formal diagnosis. This is a screening. So it's just saying that there's a prevalence of brain injury suggested. We're not formally diagnosing. And some people want to pursue a formal diagnosis and some don't. And there's pros and cons, and that's kind of a team decision. NDBIN could be brought on to help you make that determination. It's really important that people understand that typically scans are not effective in identifying post-acute brain injury. Typically, majority of brain injuries, at least the ones that are kind of those undiagnosed injuries, tend to be cellular in damage, so they're not going to show up on injury or on like your regular scans. So here's kind of an infographic or a talking point sheet that we made up at NDBIN to kind of discuss this with people, because this can be really confusing. Like, does it matter? A lot of our clients have kind of like alphabet soup by their name anyway, right? They'll have like a lot of different labels: ADHD, PTSD, depression, mental health issues and things like that. So they're like, what does this matter? One more thing. But this kind of explains how to go about it. So basically, an individual would need to see a neuropsychologist to determine whether or not they have a brain injury. And so neuropsychologists are going to schedule, typically they kind of do it in two parts, at least the ones that I've interacted with in the North Dakota area. They have the first interview. The first part is kind of more of an interview, and they just get to know you and have conversations. And then either later that same day or another day, they will have you come back and do a bunch of different tests. And they're purposely trying to see what your brain can do, or lack thereof. And then you can take those results, and the results are really helpful, but they can often be written at a pretty high level. So that is part of our role at the Brain Injury Network, is to help individuals kind of interpret those full neuropsych batteries, because they use a lot of, fancy terminology and things like that. And their resources might be a little more general, and whereas we can zoom in and say, like, okay, you live in Grand Forks, let's have you go see this specific provider, and we can kind of map that all out for you. So it's good if you do decide to pursue formal diagnosis that you bring in NDBIN to kind of help interpret that, because it can be confusing, but it can be really nice because it can show us basically your strengths and your weaknesses about your brain. And so we do have the neuropsychologists in North Dakota listed on our resource directory. There are not many, and so I would recommend calling and getting on the schedule sooner rather than later, because they do schedule fairly far out. But if your client does screen positive, and even they don't necessarily have to pursue a formal diagnosis, but you at the very least, I would think, should do a referral to us at NDBIN. We have a referral form on our website. It's in the top right-hand corner. It says client referral. You can fill that out. A family member, the individual themselves can fill it out. Also, if the paperwork is too much, you can also just call and Nikki can fill in that referral form on the phone with you as well. Never a cost for our services, and we do not require formal diagnosis in order to work with us. So we just need someone that self-identifies as having had a brain injury and then is a resident of North Dakota. Some of those border cities, like I'd say as far as like Crookston, or 30, 45 miles out on the Minnesota side, same in South Dakota, we kind of serve those clients, but really it probably makes more sense if they're further into Minnesota that they go with like the Minnesota Brain Injury Alliance, or Montana. South Dakota have resources as well. So we can help get that set up and provide a warm handoff too. But that is our referral information. So here's kind of what we do. So it's important to keep in mind that we are the resource center for brain injury. So we are not a direct service provider. But what we will help with is community resources. So like the example I just gave, if you live in Grand Forks and you're looking for resources, we can help, say the places that we find the most helpful in terms of brain injury. We can provide brain injury information, so we can do our symptom inventory, and then we can determine what your strengths and weaknesses are based on that, and what tip sheets might match with your symptoms. So let's say you score high in the area of attention, then we would provide you with attention tip sheets. I'm going to talk about all of that soon. Support groups, we are in touch with either the facilitators if we aren't the facilitator ourselves, so we can help give you the information and help try to get you to support group if maybe transportation's a barrier. Survivor Connections is a great program we offer. Nikki runs that one, and that is a phone-based call kind of support group, if you will, but it's phone-based, and it's a veteran survivor, so meaning someone that's had their injury for quite a while, and then someone that's maybe newer to injury or just been identified. Then the three of them, Nikki and the two survivors, have a phone call regularly and kind of just touch base and troubleshoot and talk about anything that might be going on. Case consultation, it would be, so let's say for you guys on this call, if you are a care coordinator or a peer support specialist, you can contact NDBIN and we can kind of kind of tag team and double it up, and we can consult and give ideas on goals and how to make life a little easier for this client in both from your perspective and from their perspective. And then technical assistance is a little bit more in depth. I would say that's a little more of what I do with my school age youth. And so my students, if a student has a brain injury and returns to the classroom and they want some support, I will go out and provide some of that technical assistance. But we also do that with home-based entities as well. So North Dakota is recently has opened several adult foster homes, and so we give technical assistance to those adult foster homes as well, and writing behavior plans and training of staff. And we just heard this morning, Nikki shared with us that the one in Leeds has four individuals right now, so that's very exciting. So Nikki's working on getting a training set up for all of their staff, so that's great. But then also we're very flexible, like what we can and can't do, just ask. There's probably something we can help with, and if we can't help, we can certainly try and find the person that can, so, or the agency or whatever would make the most sense. So there is, when you make a referral, all these are listed, so you can check the boxes. There's also an other, so like, again, if you don't see it, just ask and we can try to help. So the really important thing that we want to try to get across by doing all of these Learn at Lunch is that you can treat someone with brain injury by providing support and resources and not having to separate it out. You don't have to be like really, really well versed in the brain and the lobes and all the formal science part of the brain. You just kind of need to know how to work with people, because we all have a brain, right? And we all at one point probably utilized a lot of the strategies that we recommend, and we just don't want you to be shied away from brain injury. So we hope that these conversations and these presentations we're having are making you more comfortable about talking about this with your clients, because it can really empower them and be important to provide the right supports for them. So it's really important after brain injury to kind of connect all the dots, and that's important to know that they're all connected and they all kind of rely on each other. So brain injury, being our brain controls everything we do, oftentimes it can impact everything we do. And then also it's our brain that's determining what are the deficits that we have are now, and it doesn't always do a really great job of that. So we give the example of, if you break your leg, it's your brain that tells you that your leg is broken and that it hurts. Well, we break our brain, it's our brain that's also telling us it's broken and it hurts and it's not working right, but it isn't always able to do the best job. So it's really important to think about kind of physical and medical things going on for an individual: cognition and communication, emotions and behaviors. All of those things are very closely linked. And so now we're going to kind of go over them more in depth. But ROBOTS is just kind of a great acronym, I think, that all of you should print and put on your walls, and this will help you with all individuals you work with. But basically, you want to reduce the amount of information that you give. That's what the R stands for. So talk in really simple terms, and try not to get super wordy and lengthy, just really being brief. We want to give one instruction at a time to allow for that processing speed. Oftentimes individuals with a brain injury have delayed processing, and so they need that think time. The W in ROBOTS is for written and verbal whenever possible. 83% of what we learn comes from our eyes. We need visuals. We need to see things. Could you imagine me doing this presentation without any kind of visuals? We would all be really zoned out, rather than focusing in a little bit more. So even asking for like after visit summaries at doctor's appointments, or using the back of the box of mac and cheese for the instructions, really just using your environment to help. Breaks are helpful. So brain breaks are something that an individual with a brain injury is not going to stay charged all day long. They need breaks built into their day. Their breaks should be scheduled just like their time on, like their appointments. Breaks should also be scheduled as well. I would recommend one mid-morning, one mid-afternoon, maybe one early evening, depending on the person. If they're worried they're going to fall asleep, we want them to set an alarm. But basically, this is 10 to 20 minutes quiet, little to no stimulation of any kind. So no playing on phones or any of that. Just chill time, just time to breathe. O stands for often is better. Routines help. When our brain knows what's coming next, our brain does much better. So this works well for memory, it works well for anxiety, it works well for a lot of different components that are often involved after a brain injury. So anytime we can have a routine, getting up around the same time every day, going to bed around the same time, eating meals, taking medication, it can help us remember to do all of that at a better time or at the right time. A is to ask person to paraphrase and repeat. This is a really good kind of gauge of comprehension of cognition. What did they understand from the conversation that you just had? And so if you have them say things back in your own words, in their own words, that will help a lot. We want to take time and go slowly. I know when I ask a client a question, if they have a long wait time, I kind of count in my head just to help myself not fire another question back at them. Shannon and I teach a class at the Downtown Engagement Center in Fargo on Mondays, and so yesterday, a gentleman that attended was talking about this, how he gets really, it's a trigger for him when people keep firing questions at him before he's even really answered the first question. So just be thinking about that. And then simple and organized information is the best. So again, using very simple words, like I always give the example of instead of sibling, say brother or sister. Instead of like geriatric, say old. Just try to use more simple language whenever possible. So this is why individuals with brain injury need a break. Why they need breaks throughout their day is because they have fatigue, and it's often kind of a double whammy for them. They're not just tired, it's really, really exasperated. They probably have fatigue from the injury itself. Our brain is responsible for keeping us alert and aroused and attentive and responsive. And so if that part of the brain gets damaged, then oftentimes we might not be that way or not be as alert as we could be. And then secondary fatigue is kind of that trying to keep it all together. I always talk about brain injury is kind of a unique disability area. They're born typical, develop typically, and then there's some type of incident that happens that kind of changes everything. And so now they're dealing with the anxiety of that, because now I have delayed processing and I also can't find my words. And so that's going to make me tired because I'm trying to kind of find my words and working my brain a lot. And I'm sad because a lot of my relationships are now disenfranchised. My friends stopped calling because I was tired all the time. Just kind of it's this vicious cycle that really, really weighs heavily on someone with a brain injury. So that's just really highlighting that importance of those brain breaks. We will go back and do we'll do informal and formal interviews of clients that we've worked with for many years, and one of them always sticks with me. She talks a lot about this and about how at first she thought I was so silly to tell her to take a brain break, and she was offended. She was like, I don't need a nap, I'm an adult. And but once she started taking them, it really, really helped her a lot. And so she said she wishes she would have started her brain breaks from day one of meeting us and hearing about them. Okay, so we're going to kind of dive in and talk about goals and objectives and interventions. So this is my jam. This is my wheelhouse. So I'm a special education teacher by trade. So that's what I did for 10 years before I started at the Brain Injury Network about 5 years ago. And I think it's really important that clients have a good plan in place, and that's in writing and that people can see and be working towards. Hopefully your agency or the state, you're using the plans that are provided, like the IPPs and personal care plans and all of those kinds of things. But sometimes those are written very broadly, especially the goals on them can be written very broad. And so, but that is this is how it kind of breaks down. So when we write an IEP at the school level, an individualized education plan, typically we write all this out into the plan, and I would like to see this in plans across North Dakota too for our adults. So let's say we have the goal of Mary's going to be independent with her finances. So that's pretty broad, and we have seen this on clients' paperwork. But now it's that, how do we get them to that point? And so NDBIN can help you with objectives, but it's important to think about them basically as like the specific steps in order to get to that big end goal. So she's not just going to become independent overnight, right? We have to teach her how to get there. And this is just a very generalized example of an objective, but maybe she's going to start logging her spending receipts into like a check register with staff support. And I'm going to talk about in a minute that move from a prompted to an independent level. But basically we want her to start being more aware of her spending, right? So maybe this is a old school example. Maybe it even could just be as she goes on to her online banking and checks that the correct amount was charged or something like that. But however it makes more sense, maybe Mary doesn't like using technology. So maybe a check register is more appropriate for her. But if she was a younger client, maybe we would want to have it online. So goals should be very client person centered for what works for them and what their strengths and weaknesses. And like maybe Mary can't write on a tiny little check register that the bank provides, and maybe we need to like blow it up for her and make it bigger for her. That would be another example of like person centered in a way that she can do it. And then, so the interventions, the strategies, the accommodations, all those words we kind of tend to use interchangeably. But basically it's how you're going to help them get to that objective. So staff are going to prompt Mary to get her receipt from the cash register every time she shops. And again, when you think back to rowboats had us creating routine, right? So if she's prompted every time, hopefully maybe you can fade that out and not have to verbally say, Mary, get your receipt or check your receipt, or when we get home to put it into your check register. So this is kind of how this looks when we move towards supporting independence. So we always want to start with the least amount. Like maybe, if Mary could do this by herself, then that really wouldn't be a goal for her, right? Because that wouldn't make sense. But she's not already independently there. But if she was, she could do that all by herself. She could get the receipt, she could take it home and log it in her check register. But if she can't, then we maybe need to provide that verbal prompt. So that's just like it sounds, just asking them, telling them with words what to do. Gestural prompts are when we're also giving an action as well as pairing it with words. So we're showing her, we're pointing to the receipt, we're modeling, we're using our hands basically and gesturing while also verbalizing. You can model the prompt too, so you can show them how you do it. So even, if you go to the store too, you're allowed to buy something as well. So buy something and model it and show them, okay, I got my receipt, I'm going to stick it in my wallet and for when we get home, or however you want to do that. And then the positional prompt, that's going to be your client with more of probably a really severe injury that's going to need maybe that hand over hand if they're really involved physically, and they might need you to guide them with all of the above. So they kind of build on each other, as you can see. So we want clients ideally to get from more of like that model and gesturing and verbal to just being able to do it all by themselves. But again, that's not going to happen overnight, and it's pretty slow, and it's something we slowly build up to. And this is very, very generalized because we have all different people listening in on this call. But if you want NDBIN to help you determine, what makes most sense for my client, that's really one of our roles. And so we'd be happy to do that and help you kind of determine what like prompt level would be the most appropriate for that person. I'm going to dive a little bit into some of like the cognitive stuff as well, because this is going to be important, and this is related to the tip sheets that will be provided. So hopefully after your client screens positive for brain injury, that also entails a symptom inventory. So that was the 9-page document that I showed you last week that is basically the 9 different areas that the brain is mostly cognitively responsible for. And so we have clients take that, and it's a self-report basically saying how much different symptoms of brain injury are bothering them. From, extremely bothered, very bothered, slightly bothered. We ask, do you have this problem, but it doesn't bother you, or do you not have this problem at all? So it's a scale that they answer on. But one of them is the area of attention. So I just like to visit about attention a little bit because it is important. It influences all of our other cognitive skills. So our attention helps us decide, how to allocate resources. But there are different levels of attention, and so it's kind of important to understand them a little bit. So I'm just going to explain them to you. So the first stair step there is called focused attention. That's very, very basic. That's reading a billboard while we're driving. So it's noticing, but not really like doing anything with something. It's very, very quick, like a couple seconds. That's our focused attention. Individuals with brain injury usually are okay with that focus piece. That's not a huge concern of ours. Sustained attention, however, is a lot different for someone with brain injury. So sustained attention is what a lot of you, at least hopefully, are doing right now. You're listening to me talk, right, for this hour. So you're paying attention to something over a period of time. And that period of time piece is hard after brain injury because attention is kind of one of our first things to go. It's almost like our clients often have the symptomology that would be associated with like attention deficit disorder, like ADD and ADHD. And so that sustained attention piece can be really hard. And that's where we want to have you provide visuals and have you offer breaks for movement and not expect them to stay seated for a really long amount of time. A lot of our clients, if you ask them what their favorite, movie or TV show, it's mostly TV shows, and they're mostly pretty short, where the whole kind of message is wrapped up in like a 30-minute segment. They usually don't like the longer drama type shows. That might be a good way to kind of just even do an icebreaker conversation too with a client. What's your favorite movie or show? And you might be surprised what you learn. So selective attention is me being able to watch that show or listen to that speaker while also tuning out things going on around me, like my neighbor snow blowing or my dog barking earlier was like a perfect example of selective attention. So those of you that were really distracted by my dog, you probably struggled with your selective attention, right? It's that ability to kind of like weed out what we can and can't listen to. And so these are the people that really struggle with like the pencil tapper. If you're sitting in like a conference and that pencil tapper next to you is driving you nuts, that's your selective attention kind of getting in the way. And so that can be tricky after brain injury too. They will often listen to the pencil tapper over what was being said. So that's why we want you to paraphrase and ask them to repeat things that were said, because we're seeing if they were paying attention and understanding. The next stop on the step there is alternating attention. So let's say I'm again watching that longer drama show and my daughter comes into the room and needs something, asks a question, and I answer her question, and then she goes away and I go back to the show. I might need to rewind, right? Or if I was on the phone talking to someone, I might prompt them and say like, oh, where were we in this conversation? Just getting back on track. And someone with brain injury for sure is going to kind of need that like prompt as to what you were talking about or where you were in the movie or in the conversation that you were just having if their attention gets interrupted. And then the very last level of attention is divided. And so that is basically multitasking. And there's a neuropsychologist that says that, no one should be multitasking, and that when you do multitask, one of the things you're working on is not getting its full level of support that it needs. But the best example that I love, that I think a lot of us can relate to for that divided attention is, let's say I am driving and I am jamming out, got my tunes on, and I get lost. I can't see the chat, but hopefully you're going to tell me in the chat, or you can shout it out too. What are you going to do with that volume of the music if you get lost? What's the first thing you reach for? Turn it down, right? You're going to turn down that volume. but are your ears finding where you need to go? Not really, right? And so it's that divide, it's that attention piece, that auditory, the music or whatever you're listening to is pulling away from your attention. And so that's why when we want to like learn something and teach something, we want it to be in an environment that's not distracting and that's quiet. So those are kind of all the examples of the levels of attention. So when someone struggles with attention, it's a lot more complicated than just one thing is our point in this slide. And then here are kind of some strategies. I went over a few already. That vigorous movement, I do like, I think does work well. You know, have the person with the brain injury be like the runner, have them go grab something before you start a hard task, or even, you know, go check their mailbox or whatever it is that you can have them go do. When I'm in the classroom setting, I tell the teacher to, you know, go have them be the kid that gets the staples or something. And then I always say, you know, like a pro tip, you don't have to need the staples, just send them to do something that hopefully feels a little bit meaningful, but also gets that brain ready to learn. So yeah, I think I'm not going to read all those too because I want to keep going. But here's what the attention chip sheet looks like. So let's say you have that client, they screened positive, they did the symptom inventory, and now they scored high in attention. So we're going to provide you with these tip sheets, and there's one for the client, which is this one that just says attention, and then the one that says for professionals would be for you guys. And I always, you know, I don't know, we went with professionals because it was the best at the time, but I wish we maybe didn't say professional, but like caregiver, anyone honestly that's involved with the client can benefit from that tip sheet. It's just written from another perspective. So husbands, wives, family, friends, but also you know, peer supports and care coordinators, anyone really involved with them can learn from the tip sheets. So they are double-sided. So the front kind of has what to look for and kind of definitions. And then the back is really like the accommodations and the strategies to try. So that's kind of your area of attention. So memory is also part of that cognitive symptom inventory that you're hopefully gave your client. And what, you know, memory impairment makes basically it difficult to recall, organize, and process information. And in particular with brain injury, they're going to struggle with their short-term memory. So with new information, they oftentimes can tell us things about their past from a long time ago before injury, but typically it's those newer things. And so there's some strategies that we can utilize. We can break instruction down into small chunks. 4 is perfect. 4 would be the maximum though. So depending on the client, you might want to go more like 2-step directions or even 1, like we said in rowboats. You want to focus on one thing at a time. You want to present information in a lot of ways. Whenever I'm at the deck talking, I always try to talk about their senses, and I have them list their senses, because anytime we can incorporate our 5 senses when we're trying to learn, then it'll sink into our brain better. So we want to, you know, see it with our eyes. We want to use our hand and write it down. We want to visualize it. We want to model it and see it. So WH questions are referring to like who, what, when, where, why, and how. And so asking a lot of those kinds of questions can help trigger individuals' memory, as well as, you know, hopefully keep things and take them down into that long-term memory more than the short term, where it eventually goes away. And then I teach, you teach lights up different parts of the brain. So when I'm teaching you something, that's lighting up one part of my brain. But when I'm learning something, or it's a different part. So it's good to have them do a little of that too, you know. I'm going to show you how I make mac and cheese. Now you're going to show me how you make mac and cheese, or how you send an email, or tie your shoes, or whatever makes most sense for the client that you work with, or like the example earlier, how I balance my checkbook, that kind of thing. So here's the memory tip sheet. Just want to kind of show you guys what all these look like, because what we've been doing a lot lately is, you know, even at the deck, I will hand someone a stack of these, and I hope they end up with you guys as care coordinators and peer supports. If they don't, you can always find them on our website or contact us to get you some too. But they do look exactly the same. It's just noted differently for professionals along the top. So the back is going to really have the helpful strategies and the accommodations if that individual is struggling with their memory. Processing. So this is the brain's ability. It's decreased oftentimes after brain injury to process the information that's coming in. And so these are individuals that often have a hard time keeping up with conversation. They're often missing steps, or they don't follow the directions as explained. Oftentimes these are the people that look lazy, or the politically correct way would be to say unmotivated or slow moving. And these often people look like they're uncooperative, or they're not being responsive to what you're asking, but oftentimes they're still processing what it was that you asked. So some ways to help with that, some intervention strategies, you can do pre-process and post-process recaps. We usually recommend this, like especially in like a group setting, such as like an AA maybe, or something that's even faster paced than that too, if they can do kind of like a little pre-session with the leader of the group, then attend the group, and then a post group, here's what we learned, this is what we talked about. We want to allow for delays in response. Again, that's when I talked about how I count in my head. That's how I allow for my delay, but you can come up with ways to do that on your own too, or whatever way makes sense for you. Being brief and concise, giving instructions simply, providing those copies of meetings and notes and summaries, and then reporting. You can record sometimes. Places will let you record important meetings or instructions to get, again, that verbal and sometimes that visual piece as well. So here's what the delayed processing tip sheet looks like. So keep an eye out for those ones if your clients got scored high in that area. Organization is another area that the symptom inventory is looking at. So that's basically our ability to use resources in an effective way to get stuff done, is the way I say that in basic terms. But these are our people that are late and that miss appointments. These are the people that have trouble remembering things that were scheduled. These are the people that don't take their meds at the right date and time. They might not know what day and time it is. So organization sounds, I think, when we just listen, from the outside perspective and don't really look at all the examples, like, oh, it's kind of being nitpicky, but really these are very important big things, like especially that medication management piece. That's going to kind of throw off your whole day if you're not taking your meds at the correct time. So we want you to have good strategies in place for organization, like establishing a daily routine. Because again, when we have a routine, when our brain knows what's coming next, we do much, much better. We want to touch it once. So when I go to the mailbox and I get my mail, I'm always going to put it back when I bring it in my house in the same spot, so that when I'm looking for that bill to pay later, my brain only has to retrace that one pathway to find that item I'm looking for. And so that leads us to the home for everything. So my bills maybe always go in a certain spot in my house. My keys always go in a certain spot. My remote. If you use those strategies and keep everything in the same spot, you're going to spend a lot of less time wasted on finding stuff. These strategies really help a lot. You need a system. Everyone should have some type of system, and a lot of your clients are probably going to need you to like explicitly help them and pick it together, and need a lot of support deciding on what system works best for them. And then you can't just teach it once. It's something that's going to need to be reviewed probably daily in the beginning, and weekly and monthly. And you're going to want to have a lot of patience, because you're probably going to get asked for help a lot on how to figure all that out. But once it's in place, then I think you can fade it out. Again, it kind of moves from that prompted, that independence to more of a prompted level. We want appointments set up at the same time on the same day. So like ND Bin is always at the deck on Mondays at noon. And that's because if we sometimes went on Tuesdays and sometimes Thursdays and sometimes at 1 and sometimes at 3, people would never have that consistency, right? And they need that in order to be successful. So we find even with you like care coordinators and those pieces, if you can do that, have that consistent time, and don't worry about rescheduling. I think you just cancel. If you have to miss a week, you miss a week and you cancel and you reschedule for the same date and time that you always do, because they get really, really thrown off when we change the schedule up on them. And then it will probably waste like 2 or 3 meetings just trying to get yourself back on track. Switching between tasks can be really hard for our clients. And so using timers or watches to alert them can be really helpful. And then breaking down tasks and crossing them off as you go. And I always tell clients, when you're going to make a list, I think the first thing you put on the list is make a list so you can cross it off and you have that kind of that self-motivation and that sense of pride and like, oh, I got something done at least, right? But yeah, this can even mean tasks in general. So like laundry, rather than have laundry written on our list, we can have, take all of our dirty clothes down to the laundry room, sort dirty clothes, put in washer. You can have each step written out. That's called like task analysis, and we can help you do that at NDBIN too. There's a cool thing if no one's played with Canva before. I feel like I'm like a graphic designer when I play with Canva, but Canva's pretty cool. And you can do a lot of task analysis really easily. I did one recently for a young lady learning how to shave her legs, for example. And then we laminated it so it can go right up in the shower. So it just got taped into her shower, and then it's there for her for those steps as she's navigating that part of adulthood, right? So organization tip sheet looks like this. So keep your eyes out for that one. Another thing that that is being gauged on the symptom inventory is mental inflexibility. These are people that, it's kind of their way or the highway, or at least it definitely appears that way. And they really struggle with changing their mind after a decision's been made or understanding another's approach or perspective. I always find this one interesting. It's the way it's phrased on the symptom inventory is like, I don't understand why people do things differently than me. And a lot of our clients say that extremely bothers them, and it's kind of interesting. So they really struggle with like that empathy piece and that just like flexible thinking. So some ways to help that, we can notify in advance of schedule or routine changes. To be honest, if I've given you this example before, I'm sorry, but I'm going to because I think it's a great one. But I had a guy once that talked about, cooking meals with his family and how the kids would want to help him cook, and that really stressed him out. But instead of it being every day you can cook with dad, we made it into a scheduled part of the week. And so dad knew when it was coming, kids knew when it was coming, and then he could also strategically plan the meal to be more of a kid friendly, or else like a busy work meal too, like something where they can, unwrap or cut up or do whatever, to involve themselves in the meal, and dad could plan that. And it helped a lot. It really helped them be able to do that task together as a family, which they should be able to do, but it also helped dad not be so stressed out about it. We want to help with transitions, especially if people are, leaving. If we can do like warm handoffs anytime we can, that makes a world of difference. Just having that either that face-to-face or that email or that phone call that's, hopefully the client is included on as well. And then we just want to help them think about empathy and how to role play and try to just think about things from different points of view. There's a lot of different ways you can role play that depending on your clients. So there is the mental inflexibility tip sheet and what that one looks like. Okay, we're going to dive a little bit into kind of the behavioral side of things, because hopefully though you have enough of the cognitive stuff in place where your client isn't having behaviors, but we know that that's probably not realistic, right? And not real world. So, but ideally that's what's in place. So emotional and behavioral changes are caused by, we don't know, some kind of chicken or egg. That's a mix of things. So it can be the damage to the brain itself. Our emotional processing is in the brain. So if that area got damaged, then that area could be dysregulated. It can be coping with the problems following the brain injury, like I talked about on that fatigue slide, that anxiety and depression, and relationships look different now, and maybe I can't drive anymore, and that makes me very mad, and lots of just different coping things that need to happen after brain injury. And then what were they like before? If they were a jerk before, they're probably still going to kind of be a jerk. If they were nice, they'll probably be nice. It's just that our personality doesn't completely change after a brain injury. The classic hallmark 3 I's, we call them impulsivity, irritability, and impatience. Very, very classic hallmarks of someone with brain injury. They're going to look different from person to person. Impulsivity might look like shoplifting for one person, and it might look like overspending to another. It's just very different depending on like what what category or what their means are, but it's still impulsivity. So making those heat of the moment decisions. Irritability is something, in our society we all have. Like we talk about words like hangry, right? Like we get so hungry that we get a little angry. And individuals with brain injury get all that too, and they get irritable just like us, but it's much more exasperated. It's a higher level. And so they really need really good coping strategies in place and how to like manage and effectively deal with that. And then impatience. I spend a lot of times talking with clients about like, what can you do while you're waiting? Because rather than, strategies like trying to find the shortest line and things like that, the odds are you're probably going to have to wait at some point in your life for something. And so what can you do while you're waiting? You can do deep breathing. You can do simple, basic yoga things that people won't even notice that you're doing. You can do crosswords, make shopping lists, all kinds of stuff, but just kind of working on that impatience piece. Socially, our clients tend to be a little bit inappropriate from time to time. They'll say things that kind of that tip of the tongue that some of us are able to inhibit and not say out loud often might come out, and so they might need that prompting, like what you said isn't really okay. That probably should have just been in your head rather than verbally out loud, and just helping them recognize that in a nice, respectful, kind of pull them aside, not in front of a big group of people or anything like that, but just teaching how to act appropriately can go a long way. We tend to see people have a really overinflated sense of self, so really big kind of egos and their way or the highway, or we see kind of meek and mild and smile and nod and everything's okay. So with both people, they still need services, right? But it just is going to look a lot different, and they're, the strategies that we utilize are going to be different as well. And just that whole reduced frustration of tolerance. Hopefully you've taught coping strategies and you've used the tips and tricks from the tip sheets, and hopefully they're not getting to that point, but that is a very common thing. And so I'm gonna skip this one. I like to show you, sorry, this one. I just want to make sure I get through everything. So cognitive and behavioral spiral. So basically, this is a visual of what happens before an emotional outburst. So someone with brain injury has cognitive deficits from the injury. And that's why we want you to use that symptom inventory first. But oftentimes, if we don't, use that symptom inventory and have good accommodations in place, they're going to become anxious and frustrated. And that is going to distract them, causing them to be less able to focus and concentrate and process. And then they're even more worried about how they look, and oh my gosh, everybody thinks I'm an idiot, and just then they really start to get sweaty and nervous, and then that's when the F-bombs fly, or the stomping, or the door slamming, or whatever it is that this client does, their emotional outburst happens. So that's a very nice visual for why we want you to implement strategies to help with the cognition piece before it hopefully gets to all this other stuff. So we do have an emotional dysregulation tip sheet. So, you know, these individuals are the ones that often do things without a regard for safety. They're very impulsive, very, you know, don't look both ways before crossing street type personalities. Um, and often have trouble knowing when to stop an activity. They'll get very like hyper focused in on something. And that's when those timers come into play. And we, you know, it's okay to do that puzzle or play that video game, but only for an hour or a half hour, whatever is agreed upon by the individual on the team. And I think it's very important to keep in mind that moods are going to shift really rapidly. So this clientele tends to kind of go from 0 to 60. And if you're familiar at all with the ACEs study, I do talk a lot with clients at the deck, particularly about ACEs. ACEs stands for Adverse Childhood Experiences, and they did a study in the 90s, and they basically came up with 10 questions that are all adverse childhood experiences. They're all terrible things that should never happen to children that do happen to children. Well, basically, I was taught that the higher someone's ACEs score is, the higher their resting heart rate is. So these individuals, especially if they have some trauma from their past and a high ACE score, they're probably resting at like 30 anyway. So they're really not going from 0 to 60. They're going more like 30 to 60, but their resting is higher than someone without that history of trauma. So some things that we can do when an individual is having kind of like crisis, we can take them to a quiet area. Again, turning that radio down, reducing those auditory and visual distractions, and just allowing them to breathe and think. You can ask them to talk out loud. They can write it down on paper. They can record it into their phone. They don't necessarily have to do anything with that. They can delete it. They can tear it up or burn it or whatever they want to do, but they need that play their tape, like their way of like getting it out. Mindfulness is you know, getting a lot of press and good things right now, and it's because it works and it's true, and it very much helps our population of practicing mindfulness techniques. We have a whole tip sheet just on mindfulness that you would review with a client, and try maybe even downloading like the Calm app together and trying one together. Again, that modeling piece. I've talked a lot already about predictability and consistency. But then things like grounding techniques, that very last bullet point there, I think can be really helpful for individuals, and even for that like impatience piece. So if you're sitting in a waiting room and they're starting to get agitated, you can say, you know, describe, you know, something in the room in great detail for 60 seconds. Or it can be, I like to utilize the senses too, like tell me 5 things I can see, 4 things I can hear, 3 things I can smell, and go through all the senses. And that usually can kind of distract them down enough to kind of get back to that 0 or back to their baseline. So this is what the emotional dysregulation tip sheet looks like from the front side anyway. Again, all available on our website. Impulsivity, I already focused a little bit on impulsivity. It kind of does, I went over that other slide before too with the 3 I's, but it is its own standalone within the symptom inventory. And again, like I talked about, it looks very different from person to person, but those are kind of some of the things to look for. Strategies to use, I want to point out that providing incentives for accomplishing shorter term goals. I don't know that there's many of us on here that would come to work if we didn't get a paycheck. So got to think about that. What is that client's paycheck? What are they working for? What is their incentive? I think a lot of times it's basic, and it's like attention, time with you, going for a walk, time by themselves. Even generating like a list of incentives for clients can be really helpful. You know, what do they like? Do they like hot tamales or Mike and Ike's, or, you know, just different little candies and different anything? Do they like blizzards from Dairy Queen? Do they like going to the public library? Just having some type of list that staff can pull from for ideas for that. Like, you know, you get this done, then we can go do that. Stop, think, act is a way to reduce impulsivity. So it's honestly like rather than making those heat of the moment decisions, stopping in that heat of the moment, thinking about my consequences. And you can think about even, the pros and cons type consequences. So let's say I do steal this bottle of perfume that I took a liking to at the store, and I get away with it. There's still some consequences, right? You probably feel a little guilty every time you use it, but let's say you steal it and you get caught, then there's huge consequences, right? So thinking through that together and thinking about strategies and or thinking about, sorry, like the pros and cons and consequences of situations with clients together can help a lot. And then act, basically, then make your decision after you think about the consequences. And hopefully they don't steal the perfume or whatever is their impulse. Here's what impulsivity and inhibition one looks like. I do like what it says in blue there. Remember that it's not the person, it's the brain injury themselves. We have to teach them how to control those impulses. I know I'm running really short on time here, so I'm going to kind of buzz through some of these, but again, like I just talked about, just irritability looks different for someone with a brain injury, and it's not personal, and it's more likely to the injury, related to the injury and not the person themselves. There's actually a lot that goes into irritability. I really like these visuals. These are actually, we stole them from brainline.org, which is a really great resource as well, which our website does link to. But these are kind of the different dimensions of irritability. And I really like how it talks about what it looks like, and then maybe things that you might hear the individuals say when they're struggling with that, and things that might trigger. I do think this environmental one, I think just from the work I've done at the deck, I think it's huge. Even just when we have the lights on versus the lights off, the level of engagement and just the calmness in the room changes a ton. So think about that, especially if you have like overhead fluorescent lighting in your office or space. We want to be as immediate as possible with any kind of behavior, and just clear, simple, direct. I don't like what you're talking about. You're making that person uncomfortable. Just being really frank and upfront. You want to be concrete and consistent. This is not a population to schmooze with. You're kind of wasting your time and energy if you are schmoozing with them, because their processing isn't probably keeping up with all that you're saying anyways. But they do really respond best to positive reinforcement. That's very research-based. We find that the evidence shows that basically negative reinforcement does not work for this population. So we need to notice and encourage appropriate behavior as much as you can. Hey, look at you, you're on time today. You've been on time 5 out of your last 10 appointments, or however many it was. Just really, really praising appropriate behavior, and you'll see much more of it. And then being really aware of your communication, your personal space. We all have a bubble. Your client has a bubble too. Being aware of theirs, having those conversations. What is your bubble? Do you mind a pat on the shoulder or a side hug, or do you not want me to touch you at all? Body posture and motions, right? Even if her hands were lowered to her hips, she would look a lot different than with her hands on her hips like that. Tone, volume, cadence of speech. I like to mention, we talk a lot about in trainings for behavior, pass the salt voice. We want you to use a very just level, even keeled voice, like you would ask if you're having dinner with your family and you're asking someone to pass the salt. Just keeping that very, very basic, trying not to get loud and yell and get angry. I know it's much easier said than done, but try to just keep that pass the salt in mind. And this is my final slide, won'ts versus can'ts. I think brain injuries, this is the truly tricky part that we have to oftentimes determine with our clients. They often look lazy, disinterested, or unmotivated. And I think what's a lot of times happening is that our clients are really good at saving face, and they would rather look like a won't than be a can't. So they would rather look like a tough guy than admit that they can't do something, or a girl, whatever the sex of the person might be. But they're going to, play down their deficits and diminish them rather than share with you, like, I don't know how to make mac and cheese anymore, or I can't drive my own car anymore, or whatever it might be. They're going to come across more defiant and look like they're being deliberate, but it's probably more that they can't do it. And so we might need to bring it down to their level again. Like I talked about, blowing up that check register for that woman if the spaces are too small. And so that's really where NDVIN comes in to help you figure that out. So that is it. You can contact us there as our 855 number, as well as our website. Everything I talked about is available on our website, but we will also be sharing slides with Kelly as well. Any
Yes.
questions? I'm sorry, I went right up to time there.
That is okay. There was a really long statement in the chat by Cindy. I don't know if Cindy, if you want to say it out loud, or did you just want to leave it in the chat? I wasn't sure.
I guess the point I want to make is when we're evaluating people for comprehension, etc., outside of the fact that there might be a brain injury that they're also suffering from, but if individuals appear to take time, quite a bit more time than the average person, before they reply to conversations, it may just be the period of time that the brain takes to take in what the person said, then evaluate it for what the person with the hearing loss thinks they said, and then to figure out which one makes sense before they actually reply. So that can sometimes cause people to look like they're confused or just not understanding the conversation like they should. And just throwing that out there, that can be something that could be misinterpreted.
Yes, and I think Kelly, Cindy, that's a great point. So when someone does want to pursue formal diagnosis, one of the things that they have to do is go through their primary first to rule all that kind of stuff out. So like their primary is going to look at their ears and say, okay, it's not the ears. It's not, and do that physical workup before they even make the referral to the neuropsych, because the neuropsych wants to make sure that they're not missing anything physically related either. But that's a very good point that I probably did not express enough, that we want to rule all that physical stuff out before we just automatically say, yep, it's the brain injury that's causing this. But the hearing loss and tinnitus is a very common after brain injury too. That's that ringing in the ear. And so it could be tinnitus as well, which a lot of people tend to think there's nothing they can do about it, but they have determined there are a few treatments available now. And we have a really good webinar Wednesday on our recording with Dr. Kevin Fire in Fire Audiology here in Grand Forks, and he has some really neat treatments for tinnitus right now.
Oh,
so people don't have to just live with it, is my point.
Right. Erin asked a question. Do you have any webinars or trainings, and I think she meant groups, specifically for family members of those? I would assume you probably do.
Erin, I love to see your name. I just added you to my Salesforce this morning. She referred someone to Lunch and Learn yesterday, to our Lunch and Learn. So, okay. So we do powerful tools for caregivers. If that's a class that if you're not familiar with it, it's a great course, and we have 2 coming up. I can throw in the chat. It basically becomes like a mini support group, if you will. But it's a 6-week series, and we have 2 listed right now on our website. So one starts April 3rd, and one starts April 4th. So there's 2 versions of this class. There's one for adults, caregivers of adults with chronic conditions, and then there's one for caregivers of children with special health and behavioral needs. So if like dates and times work better though, for let's say I have a child and Wednesdays work better for me, really the curriculum isn't that much different. It's more that the like conversations and the people you'd meet would be different, you know? But really I wouldn't worry too much about like content itself does not really change a ton from, it's like the
Okay.
examples change. But, you know, that's an area I think we're gonna eventually dive much deeper into, Erin, because we just got Shannon Stanky on board, and she was a caregiver to her husband with brain injury for many years. And so I think we are going to definitely, we have a caregiver corner. I'll throw that in the chat too. But really, we hope to get more information in that. Yeah, here's that caregiver corner. Really, self-care is the important thing when you're caring for someone else. And that's really what Powerful Tools for Caregiver is teaching, is how to care for you so you can care for them.
Okay, there we go. That's awesome. That's really good. Does anyone else have any other questions or comments? I know we're over time, but if
Yeah.
anyone can, I mean, it happens sometimes. If you're able to stay, you can, so. No, okay. I did put in the chat a few different times the link for the survey, and then at the end of the survey, it does ask if you need CEUs or attendance. There's a link in there. You can also enter the information for last week's as well. And then for those of you that put your emails in the chat, I will get the PowerPoint out to you. Last week, I apologize. I kind of forgot it was end of month. So I had other duties that I had to do. So I made a promise that I could not keep. I was like, I'll get this out today or tomorrow. Didn't happen. I had other stuff I had to get done. So I apologize about that, but I did get it out to you. And then I think I'll also probably try to include those those support groups in the email as well. And then if you guys have any other questions, also feel free to reach out to Carly or Rebecca or Brain Injury, just the number in general. They are not a provider, but you guys can kind of refer people to getting screened and so forth. I know I had questions about how people get screened in the prison. I got a couple emails, and I'm sure that there are screenings in the prison.
Absolutely. Yep. So we just set one up via Zoom the other day. So
Yeah.
We can go into the prisons. Most of us have the clearance to do that and everything too, if they want it face to face, but we can do it virtually just like we're doing right now.
Okay.
So, yeah.
Yeah, I had a couple emails about that, and I said I'm
Yep.
pretty sure they do it in the prison too. So
Yes, absolutely.
Okay. All right.
Yeah,
Awesome.
especially, yeah. And yeah,
Okay.
that's the conversation we're having, is hopefully DOCR will start screening universally too, but
Okay.
for now, yes, you can
Right.
definitely
Okay.
be screened.
And then for those that are care coordinators and peer supports that work with Community Connect program and Fruits Recovery for that matter, but Community Connect, remember on our application, we do ask question about if a person has been, knocked out or has fallen or had, some sort of injury, possible injury to their head, because we want you guys to look at that. And if a person does answer that, we're hoping that you can work with them to help them get screened to see if they do have brain injury. Because there are possible different services or different support that a person could possibly get if they, qualify. I don't exactly know 100% of everything that's out there, but then even just knowing too, that is the first step, you know? So just make sure that you are looking at that. That's very important. So, and I think all of us can kind of use some of these tips as well too. So yes, but if there are not any other questions, everyone is free to go about this lovely day. Fingers crossed for good weather for the rest of the season.
Yes,
Thank-
absolutely. Thank you so much for having us.
Yes, thank you everyone, and be safe out there walking, because that's number one reason for people to fall. And
Right. Yep.
so yes, be careful.
For referrals. Yep,
Yes.
exactly.
Thank you guys so much. Have a wonderful day. And thank you,
Bye.
Carly, and thank you, Rebecca.